This session is going to be very lively as well as a good learning experience for all of you, I am sure. And we have taken the trouble to compile all the previous year questions which are important. I'm sure if you go through this, pediatrics, you can do very well in your entrance exam. Now, I'm going to go to the questions now. Please look at this and then we'll respond. The first question here is, which can be used as an alternative to other than mother's milk for low birth weight babies? The option is cow's milk, preterm formula, term formula, human donor milk. If you ask me, this is a very easy question. Nobody should find it difficult at all. So the option here, oh, I see Ketan Bhagat, good evening. KK, good evening. I'm sure you saw the question now. What's the option? D. Yeah. I see Sakshi and KK. D is the correct answer. Human donor milk is the best substitute for baby's own mother's milk, especially for low birth weight. Now, the difference between cow's milk and mother's milk is everybody should know. Both have same quantity of water, both give the same calories, that is 67 calories per 100 ml. But when it comes to protein, the cow's milk and the human milk. In human milk, you can roughly remember it is 1 gram per 100 ml. The range is 0.9 to 1.5 grams. And the protein content in cow's milk is more. That's roughly 3 times the more, 3.3. And then comes fat is almost same. Lactose, when you see, mother's milk has more lactose than cow's milk. And whey protein here is 60-40 ratio. The casein is 40, whey protein is 60. Whereas in cow's milk, it's 48 and 82, 4.8 and, sorry, 82 and 18. Now, calcium content in the cow's milk is more, all of us know, and phosphorus is more. When humanizing the milk, what we have to do is, we have to see that the cow's milk, let's say, has more protein, more calcium, and more phosphorus. Let's accept now for the low birth weight baby, the best milk is human donor milk. Good evening, Sakshi. Good evening, Dr. Jain. We go to the next question now. Again, it's an easy question for me. A 4-year-old male baby, body weight of 15 kg, height of 100 centimeter, is admitted with with renal failure. His blood urea is 100 milligram per deciliter. Serum creatinine is 1 milligram per deciliter. What is the closest calculated eGFR in the patient? Yes, the answer is, I don't see the answer here. Here the answer is 40 ml per minute per 1.73 meter square. You should know the body surface area formula is eGFR is calculated for, it is ml per minute per 1.73 meter square. There's a constant K into height in centimeter. Serum creatinine is in milligram per deciliter. Here the constant is 0.43, and this can be used for GFR between 15 to 75 ml per minute per 1.73 meter square, and can be done age between 1 to 16 years. So the answer here was B, that is 40 ml. If you say 0.4 into height of the baby was 100 and serum creatinine was 1. So it was 40 ml per minute per 1.73 meter square. I hope this question is easy. Yes, the next question is, adrenocorticotropic hormone is the drug of choice in which of the following conditions? Anybody? Please write the answer. Sanjay says D. B. Dr. Jane, B. Yes. Dr. Jane, B. No, it's C. KK says the right answer is West syndrome. Yes. Sakshi, KK, and Dr. Jane, C. Right answer. Here, West syndrome is a typical triad of epileptic spasm, that's myoclonic seizures, EEG, showing hypsarrhythmia, and mental retardation. It's a very bad disease to have. The children will definitely have global developmental delay and typical hypsarrhythmia in EEG, and the child comes for refractory seizures, typically myoclonic seizure. I'm sure all of you know how the myoclonic seizure comes. It comes like sudden flexion of the head. Sometimes the hands will go like this, that's flexor spasm. Sometimes the hands will go extension. So once you decide it's myoclonic seizure, you do an EEG. If there is a hypsarrhythmia and there is global developmental delay, typically West syndrome. And the drug of choice here is ACTH. ACTH is the only, probably if somebody can ask you which is the hormone used in treatment of seizures in babies, is ACTH. Otherwise, it is prednisolone. So I hope this question was easy for you. Next question, regarding urinary tract infection in children, which of the following is true? When I construct MCQ, initially I used to think like, let's say, MCQ helps you to think analytically. It helps you to be very specific in your answer. So, but when we construct MCQs, the stem and the options, if they are very short, the question is likely to be easy. But please be careful if a question has except, true, false, and if there are double negative, we should be very careful. Here, the question is regarding urinary tract infection in children, which of the following is true? The answer is most common cause of UTI in Streptococcus pneumoniae. Bladder bowel dysfunction is the risk factor in UTI. Cotrimoxazole is not given. MCU is done in children with recurrent UTI. So you can see the options here. Most of the time, bowel bladder dysfunction is common in these children, and MCU is done in all children who have recurrent UTI. Okay, in a male baby with poor urinary stream, with the first UTI also we can do MCU. But in girl children, recurrent UTI, we should do MCU. And bladder bowel dysfunction. This is again a learning experience for me to realize constipation increases the risk of UTI, and in UTI these children can have constipation too. So the answer here, you will take 2 and 4 together, that becomes response is B. Clear? Most common cause of UTI is E. coli. It's not streptococcal pneumonia. And cotrimoxazole we use for suppressive antibiotic in VUR, and MCU is done in all children with recurrent UTI. Next question. Handedness is seen in the age of 1 year, 2 year, 3 year, 4 years. This is very important. Like typically, you'll see at 4 or 6 months, the child learns to go with bidextrous, then it becomes unidextrous. So which year the child will have typically handedness is hand dominance. If it is in a less than 2-year-old child, okay, you will see that probably there is weakness on one side. If you see a 3-month-old using only, or a 6-month-old reaching for at left hand only and not moving the right hand, there may be problem. So if hand dominance is there, which is the answer? I see different responses here. At 3 years, okay, C is the correct answer here. By 3 years, the hand dominance should be there. In less than 2 years, if you see, let's say you see only left hand use and no right hand movement at all, it may be a clue that the child has hemiparesis or cerebral palsy. Which of the following cyanotic heart disease causes increased pulmonary blood flow? This which is the answer. Epstein's anomaly, tetralogy of Fallot, transposition of great vessels, total anomalous pulmonary venous connection. Which of this has increased pulmonary blood flow? Answer here is, yeah, I see many answering as C. C is correct here. That is, transposition of great arteries and TAPVC has increased blood flow, whereas tetralogy of Fallot and Epstein have decreased blood flow. So this question is often asked. Now let's see the algorithm, how easily you can remember this. Any child with heart disease, you will have a cyanotic heart or cyanotic heart. Let's go with the flow of cyanotic heart. In cyanotic heart, either it is decreased blood flow or it is increased blood flow. Decreased blood flow is only 2, tetralogy of Fallot and tricuspid atresia, whereas increased blood flow you'll see in TGA, TAPVC, truncus arteriosus and hypoplastic left heart syndrome. Again, a word of caution here. You remember now TOF is commonly oligemic lung field. Then tricuspid atresia, oligemic lung field. Increased blood flow in the other T's, that is TGA, TAPVC and truncus. So this is with the cyanotic heart. If you have to go through and analyze acyanotic heart disease, you can consider acyanotic heart as volume overload or pressure overload. Volume overload is typically ASD, VSD, PDA. Like where you see left to right shunts. Sometimes AV regurgitation and occasionally cardiomyopathy. But most of the time volume overload is left to right shunt for us. Whereas pressure overload, you can have outflow obstruction or inflow obstruction. The outflow obstruction is typically at the valve or below the valve or above the valve. So you have to decide now whether it is valvular pulmonic stenosis, whether it's valvular aortic stenosis or coarctation of aorta. If it's below the valve, like in double chambered right ventricle or subaortic membrane, this is rare, there may be outflow obstruction. Above the valve, when we say it's branch pulmonary stenosis, peripheral pulmonary artery stenosis or supravalvular aortic stenosis. So again, increased blood flow you get in TAPVC and TGA. A 11-year-old boy was brought to the outpatient with intentional tremors, poor scholastic performance. His sister has similar complaints. On examination, hepatomegaly is seen. The eye findings are shown in the following image. What is the probable diagnosis? Yes, Sakshi or Dr. Jain? Yeah, I think Wilson is a very easy option. You will see one typically brownish green ring here, and this is cave ring. Whenever I see cave ring in the OPD, it is one excitement for me. Most of the time cave ring is seen by slit lamp examination, but some children do have macroscopically visible cave ring, and if you see cave ring, the diagnosis is done quickly. Okay, so the answer here was very easy for me, but for you, you should remember, if you see a cave ring, it is Wilson. This is taught to you and it's a very easy question, but when a case comes with these problems, that is tremors or poor scholastic performance, you have to look at the eye and look for cave ring. Okay, this typically, if not seen also, you should get a slit lamp examination and confirm the diagnosis. Now, diagnosis is very easy here, cave ring, and the option is A. What goes wrong in Wilson disease when we say it's a multi-organ disease, it is heredofamilial, and you will see sometimes the brother sister both had the same complaint, and the brunt of the disease most of the time we see in the liver or in the brain. What do we see in the liver? hepatomegaly, jaundice, and acute hepatitis, fulminant hepatitis comes as cirrhotic liver with portal hypertension and sometimes with esophageal varices. This is one common manifestation. Usually children above 5 only or 3 to 5 years only come with jaundice, and here the history is recurrent jaundice. So if any child has recurrent jaundice, we have to be careful and entertain the possibility of Wilson disease. Look at the eye and shine a torch and see whether macroscopically cave ring is there. If macroscopically cave ring is there and you make a quick diagnosis, you are always called as a good clinician. So what does it do in the bone? It can come with joint pains like arthritis, or it may be features of rickets may be there. The next common system to be involved is CNS. And here they can come with, scholastic deterioration, handwriting deterioration, abnormal movements, dysarthria, emotional lability, or excessive salivation, mask-like faces. We don't have Parkinson in children, but if somebody gets a typical disease like this of the extrapyramidal or the basal ganglia, it is Wilson for us. So they may come with mask-like faces, have swallowing difficulty. If you have a child now with Wilson, his problem is, with medications, he is able to move and he is able to flex and extend. His gait has improved, but swallowing difficulty, he takes 1 hour to eat his normal meal. So CNS, they can have all this problem, and this macroscopically positive cave ring is a good diagnosis in clinically. If not seen, you should do a slit lamp examination and confirm. On the kidney, it can come with proximal tubular dysfunction. Heart is rarely involved. In my practice, I didn't see Wilson and heart, but they can come with congestive cardiac failure. Hematologic manifestations, sometimes they come with hemolytic anemia, acquired hemolytic anemia. This also is to be known. So if somebody asks you what is the common cause of acquired hemolytic anemia, you can say malaria. Okay, but if there is a family history of jaundice, and if there is anemia, either the patient has lost the blood in the stool, a melena, okay, because of cirrhosis, or another reason is this child has anemia probably because there is acute hemolytic anemia. So in Wilson, which is the type of hemolytic anemia you get? Your answer is hemolytic anemia. So I see now Jamula, Ramya and Rahul have joined. Good evening. The next question we go. A child presents with acute exacerbation of asthma. Which of the following would you do? Chest X-ray, oxygen administration, salbutamol nebulization 3 times in 1 hour, administration of glucocorticoids. This is MCQ. So you should know what is the priority of your work. Okay, so which is the first option for you when you say, here the answer is going to be, what will you do? Let me see the answer. Yes, Dr. Jain has written D. KK has written D. Answer is D here. Okay, so you will do oxygen first, administration of oxygen, salbutamol nebulization, that is in 20 minutes one, that means in 1 hour you give 3 times, and then give oral corticosteroids. Chest X-ray is the next priority. Okay, so how do I pick up a good student when they write exam answers? One who writes oxygen, I feel very happy. If they don't write oxygen, and then just write salbutamol and steroids, I don't think it's a correct way to do. So answer here is you will do 2, 3, 4, and the option is D. So D is the correct answer. You do chest X-ray not routinely, but there are sometimes I have done X-ray when there is asymmetry. Let's say I think there is acute wheeze, but the left side there is no air entry at all. That is the situation. You'll think of a complication. But generally, first thing as the child comes till you stabilize, you will do oxygen, nebulization, and oral steroid. And nebulization is beta agonist, that's salbutamol. In 1 hour, you can give 3 times. Now, I'm sure all of you are probably familiar with this process of how to go about this algorithm. I'm sure all of you who are preparing for exams are well versed with it. What is the primary thing here to remember is decide whether it's mild, moderate, severe. Okay, mild, moderate put on one side, severe is one. Severe, you should not waste time. So once you decide here, has come with acute or subacute, then is it asthma? Because all that visas is not asthma sometimes, but here we are discussing only asthma. So is it asthma, we will say, and the factors for asthma related, whether there is any other complication you will see, and how bad is it. So if it is life threatening, goes to ICU suddenly, and if it is mild moderate, you will try with only, like as I discussed now, salbutamol, oral steroids, oxygenation. And of course, the fifth vital, we should thank pulse oximetry. Throughout, the child should be monitored with pulse oximetry. Going to the next question now. A young man is brought to the hospital with high-grade fever and altered consciousness. Has neck rigidity, pain when bending the neck. A lumbar puncture performed, shows WBC count of 1500 cells, majority being neutrophils, and protein is 120 milligram per deciliter, glucose is 70 milligrams, whereas blood glucose is 300. How will you manage this index case? Options are piperacillin tazobactam, amphotericin flucytosine, vancomycin ceftriaxone, antitubercular treatment. I see Sahu Patil saying C, very good. Sakshi C, Dr. Jain C, very good. The answer is vancomycin and ceftriaxone. Ceftriaxone covers the gram-negative spectrum, whereas vancomycin covers the gram-positive spectrum. Here, you will not write antitubercular at all. This piperacillin tazobactam I will not opt because CNS penetration is poor. Amphotericin and flucytosine also very easy to eliminate here. You ask me this question is very easy because amphotericin you will use only for reserved cases. Here you remember now, typically it is looking like pyogenic meningitis. Okay, so it's a protein is high, cells are more, sugar is little less. So it is pyogenic meningitis. The best option for this child is vancomycin and ceftriaxone. Now, one word about piperacillin tazobactam. Very good drug, but CSF penetration is not so good. So there's nothing like ceftriaxone as good penetration. Vancomycin has good penetration, and so this option, ceftriaxone, vancomycin, should be the correct answer here. So which of the following increases the risk of recurrence of febrile seizures? Age less than 1 year, temperature 38 to 39, duration of fever less than 24 hours, duration of fever 48 hours, more than 48 hours. What's the option here? Yeah, I think everybody finds pediatrics easy. I see many correct answers. Sakshi, Jain, KK, Sahu Patil, everybody has written C. Yes, good. Because see here is, you will say febrile seizure uncommon after 48 hours. Okay, so it's in the first 24 to 48 hours. So age, vulnerable age is 6 months to 6 years. Temperature, yes, 38 to 39. Sometimes it's the rate of rise of temperature that is important. Suddenly the temperature shot and the baby developed a seizure. And most of the time the seizure is on the first day of fever, that is less than 24 hours. So here the option is C. We'll move to the next question now. Yes. In febrile, again explanation here, there are some major and minor criteria. This is important to counsel parents when they come for this. You can meet a young parent, when they come and say, they'll be very scared of febrile seizure. And they will always be asking two questions to you. Will it come again? Will this child develop seizure as they grow. Okay, so age less than 1 year, duration of fever less than 24 hours, fever between 38 to 39 is major criteria. Family history of febrile seizure, family history of epilepsy, complex febrile seizure, daycare management, male gender or sodium low at the time of admission. These are major and minor criteria. No risk factor, what is the risk of recurrence? If there is no risk factor, approximately 12%. If one risk factor is there, it becomes 25 to 50% recurrence. Two risk factors are there, 50 to 59%. More than three or more than three risk factors, it becomes 73 to 100%. When there are many risk factors, most of the time, if it's complex febrile seizure, there's always another way of managing these children. So it's good to know this major minor criteria and good to know this incidence of recurrence to counsel the parents. So I see some new people coming. Good evening, Manjunath. So we go to the next question here. Choose the most appropriate answer. I don't like this type of MCQs, okay? But then when somebody is asking, better be prepared. So if the stem is long and if the options are also long, there is a tendency for the candidate to get confused. But if you have a sound knowledge into the disease process, then you will probably find it easy. So now look at this question, which is little bit different from the usual questions that are asked. Choose the most appropriate answer. So in phenylketonuria, urine has a mousy odor. That's the assertion. The reason here is it is high levels of tyrosine, dopamine, norepinephrine are decreased. The serum levels are decreased in phenylketonuria. And the options given here are, I think people are answering this now. I see Dhanlakshmi, good evening. Yeah, right. Both assertion and reason are independently false statements. The assertion is independently a true statement, but the reason is independently a false statement. Both assertion and reason are independently true statements, but the reason is not the correct explanation for assertion. Option D here is both assertion and reason are independently true, and the reason is the correct explanation for the assertion. So what's the answer here? I see C again. Many have answered C. Sakshi, Dr. Jain, KK have answered it as C, which is correct. Both assertion and reason are independently true. Correct. Because in phenylketonuria, urine is mousy odor. Correct. Then in phenylketonuria, phenylalanine, to become tyrosine, you need phenyl hydroxylase enzyme. That is deficient. So what happens? All these other things like dopamine, tyrosine and all are decreased. Okay, so independently that is true. But the reason for urine having mousy odor is not the enzymes that is decreased dopamine, norepinephrine and tyrosine. It is because high levels of phenylalanine in the urine that causes mousy odor. The answer here is C. Is that clear? This is a little difficult question. Myself, I found it like that. But I'm sure you are more smarter in answering all this type of questions. So C is the right answer here. The mousy odor of urine in phenylketonuria is because of increased phenylalanine in the urine. So there, they attributed in the reason for other amino acids. But here it is increased phenylalanine which causes mousy odor in the urine. Of course, tyrosine, dopamine levels will be less because phenylalanine is not converted to these amino acids because phenyl hydroxylase enzyme is deficient in phenylketonuria. We move on to the next question. A child is brought to the casualty with a history of choking. On examination, there is decreased air entry in the left lung. What would be the correct management? Bronchoscopy, CT chest, ICD insertion, chest X-ray. I'm waiting for the response. Option A is 1, 2, 4. Option 2 is 1 and 2. C is 3 and 4. And D is 1 and 4. What will you do? Correct. Option D. Sahu Patil has written option D. Sakshi has written D. I think Sakshi's got everything right. Very nice. So, option 1 and 4. This child needs a bronchoscopy. This child needs a chest X-ray. I will do first chest X-ray because feasible to do immediately. And if chest X-ray shows, let's say there's a total collapse on the left lung, that's because of which the air entry is decreased, then there is need for bronchoscopy. We don't do CT scan as a first order, or nor do we insert ICD first. So the option here will be D. You will do bronchoscopy and do chest X-ray. First chest X-ray, then bronchoscopy. So in suspected foreign body aspiration, if air entry is reduced in one side and if it is radio opaque object, okay, then X-ray will help. Bronchoscopy becomes therapeutic. Recently, I had one problem. One nurse's child. She came and said, "This child has swallowed a bead." Okay, I examined. There was no decreased air entry. There was no tachypnea, just cough. So I told, if I do CT scan or chest X-ray immediately, I will look like one. I did a chest X-ray. I could not see any foreign body. I said, "Sister, I can't make out anything. Just wait one day. We will wait and see." And next morning she came in again coughing, coughing. So I did a CT thorax, and there I found a bead with the hole. This bead had gone and plugged the lumen of the lower bronchiole and had allowed air to go in. That's why clinically I got sidetracked. But CT scan showed me the bead there. But there in this MCQ that is asked, you will first do chest X-ray, then do a bronchoscopy. Chest X-ray will help you to pick a radio opaque object if it is seen, but not all foreign bodies are radio opaque. But this answer here is D. Okay. So now comes the next question. A 9-month-old boy presents with a progressive pallor and abdominal distension. The peripheral smear done is shown as in the image. Menzel's index is less than 13. What investigation need to be done in this patient? So now I wait for your response. Yes? 13. Yeah, Sakshi is right here. C. Very good. C is, you will do HPLC and you will do peripheral blood smear. The first thing you will do is peripheral blood smear. I think KK, Dr. Jain, all have answered it as C. That's right. Those who have opted for other options, please write in your brain now. I'm not going to tick this. I'm going to tick only HPLC and I'm going to do peripheral smear. Between the two, I will get peripheral smear quick response. Okay, I will have that response within maybe half a day. I will get the peripheral smear which shows microcytic hypochromic target cells, okay, anocytosis, phagocytosis, and the hallmark there is nucleated RBCs. The marrow which is in a hurry will send, immature RBCs, so you will see nucleated RBCs. So first here you will do peripheral smear and you will confirm the diagnosis by HPLC. The two options which are right are 1 and 4, so the answer becomes C here. So again, I consider this as a straightforward, simple question. Everybody should get it right. You will not opt for PTA, PTT here because hemolytic anemia, thalassemia, no business to ask for a liver dysfunction. Okay, so and bone marrow, only in certain situations in hemolytic anemia, we will do bone marrow. I can give you a spontaneous random MCQ now. Which hemolytic anemia you will clinch the diagnosis by a bone marrow? Can anybody write? This is a spontaneous question for you. Where the bone marrow will help you to pick up a hemolytic anemia. I wait 2 seconds here for an answer. You can type and tell me. No? Okay. I can give the answer for short of time. I will not wait for you to write. You can remember, like sideroblastic anemia, you will pick up only by doing a bone marrow. Okay, so you will not know from peripheral smear. So sideroblastic anemia will clinch the diagnosis by doing a bone marrow. And in sickle cell, if there is aplastic crisis, you will have to probably do a bone marrow to see what is the reason for pancytopenia. Moving on to the next question. Oh, here actually, abdominal distension pallor in a child with hepatosplenomegaly, Menzer index less than 13. Again, this can be a question for you. Less than 13 Menzer index is always a suspicion to rule out hemolytic anemia. More than 13, you still can think in terms of iron deficiency anemia. Peripheral smear will show typical target cell microcytic hypochromic anemia, and diagnosis is always confirmed by HPLC here. Moving on to the next question. A child presents with complaints of fever, rash, body ache, throat pain. Has a history of thorn prick injury recently. Which antibiotic will you give to this child? Empirical antibiotic. What is the choice here? Option A is ceftriaxone, amoxiclav, vancomycin, meropenem. All got it right. I think Dr. Jain, Sakshi, Sahu Patil, KK, right. It's B, right. It's again easy question here. Look at the catch here. The other drugs they have been, they're all parenteral antibiotics. Okay, ceftriaxone, meropenem, vancomycin. Nobody will use them as first line. And best thing is amoxiclav covers the streptococcus lesion well. And the child has presented with fever and rash body ache, which may be like in scarlet fever. Okay, scarlet fever is not so common for us in India. The last I saw was a girl who came from UK, and she was all pink, 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 pink everywhere. You know, and she said, and I was thinking, is this scarlet fever? She said, all in my school had scarlet fever. So here, if you think in terms of streptococcus, amox and clavulanic acid is the right answer. So B becomes the option for us to take. Consider it as an easy question only. So suspected scarlet fever, you will always use amoxicillin and clavulanic acid. Okay, the penicillin group of drugs are the best. Before advent of clavulanic acid, amox was our favorite, but then clavulanic acid makes the response faster. Moving on to the next question now. A child with thalassemia is undergoing multiple blood transfusion. What is the best method to detect the iron overload? Because all of us know iron overload is going to be a challenge in the treatment of hemolytic anemia, that is thalassemia children. Okay, so liver iron concentration, MRI of the myocardium, serum ferritin, or NTBI. Which one is the answer here? I see Sahu Pillai correct. A, very good. Yeah, it's liver iron concentration. Okay, if you take the liver biopsy and see how much ferritin is there, that's the best. The other options are there in the evolution of in the management of this, but here the answer is that correctly to know how much iron overload is there, you can do the ferritin in the liver. Moving on to the next question now. How would you manage a child with status epilepticus? Airway and breathing, lorazepam, propofol, thiopentone, fosphenytoin. Which combination will you use? Option A is 1, 2, 3, 4. Option B is 2, 1, 4, 3. C is 1, 3, 4, 2. D is 1, 2, 4, 3. I think everybody fine. Actually, I also don't like this type of questions, but I don't see. No, here the answer is B. Okay, B is 2143. 2143 means first, you will do airway breathing, lorazepam, fosphenytoin. Okay, and last come propofol and thiopentine. So, the most, you should always stick for the most practical one. Will not go for propofol and thiopentone for everybody first. Okay, it will not be there. So, you use your general knowledge or just go through your analytical thinking. Everybody needs airway breathing. Lorazepam is the first drug you will use. Next drug, if not, you will use fosphenytoin. And in refractory seizures only, you will use propofol, thiopentone. So, it becomes airway breathing, whichever has lorazepam and fosphenytoin. So one which has, so answer here becomes 16 is D. Okay, 1, 2 and 4 and 3. Okay, three option comes last. Okay. Yeah, I think some answers as D correct. Very nice. Okay. Right. This algorithm, I'm sure you are also familiar. I can go quickly here. Like all of us, as soon as the child arrives, what should we do? We'll always, everybody will say airway, breathing, circulation will maintain, will do fine. And pre-arrival, we may have to keep things ready. All those things which are required in the crash cart should be there. That is, you will keep a non-rebreathing mask, you will keep bag mask ventilation ready, suction ready, it may be oral nasal suction, and pulse oximeter is there. IV to start IV line, you'll keep the catheters, and probably you'll intraosseous if needed. And some of this, the best things that have happened here is, note this, that is, you all of us have glucometer, so you can show the blood sugar immediately. But similarly, you can have good report with probably sodium, potassium, calcium, magnesium, and the bicarb status of the child. So this way you can probably think what is the cause. So the two things that should happen for simultaneously: what is the cause for this status? How do I stop the seizures? So keep things ready. Ongoing seizures, if there are more than 5 minutes, you'll have to decide, how do I proceed every 5 minutes? First 5 minutes, what I will do, 6, 10, 10, 20, by 30 minutes, I should be achieving good control in these children. I'm sure it's good to, but the basic thing to remember here is benzodiazepines are very good. You say, which benzodiazepine will I use? As a postgraduate, I used diazepam. Then came midazolam. Then came lorazepam. What is the advantage of all these three? Midazolam, quick action, short action. Within 20 minutes, you will have very good action, and they last for short period only. Whereas benzodiazepine, long action, it will cover. Lorazepam is the longest action. So one of the three you can use. That is benzodiazepine. In that, it's a first now tendency to use midazolam. Then can be lorazepam. Lorazepam will cover for nearly 12 hours, and diazepam. One of them you can use, and your mind should go with simultaneously, as I said, you are controlling the seizure here. At the same time, you are giving importance to diagnostics. That is, you will do probably sodium, potassium, calcium, check the blood pressure, whether it's hypertension, encephalopathy, which has come with seizure to you, and secure a IV access. Sometimes it's difficult to get IV access in a child who is convulsing. Okay, so what we have to do that time? Maybe rectally we can give. So in next option, you can go through this. For short of time, I will go through this quite fast. When it is more than, if you have tried midazolam and or lorazepam, you have option to give phosphenitoin. Then you have option to give valproate, and then later you can go to phenobarbital, and only in some cases you will go for this propofol and ketamine. Going to the next question. A child presents with cold feet and a history of wearing socks even in the summer. On examination, lower limb pulses are diminished as compared to radial pulse. There is a prominent radiofemoral delay present. Which is the underlying condition? This should be very easy for all of you. I hope all of you, if you get this question, should answer correctly. You cannot go wrong in this at all. Yes, yeah. I say answer B here. Dr. KK has written, Dr. Jane has written B. Very good. Coarctation of aorta. Clue is very simple. Forget the socks and all. The femorals are weak. Radiofemoral delay is there. Okay. And that is typical of coarctation of aorta. So, you can diagnose coarctation in infancy. I have had the chance to detect coarctation in infancy only once, and coarctation in older children twice. I have sent for stenting. So you can detect in infancy, childhood, adolescents, or sometimes in adult ward also they may pick up a coarctation there. And here another MCQ can come. Which are the associated syndromes where you can get coarctation? Answer should be Turner syndrome first. Okay. Typically in girls, XO, you will get coarctation as a common. So one more MCQ you can have in mind now. Which condition you get coarctation as an association? You can get in von Recklinghausen disease or Noonan syndrome or congenital rubella. I have not seen in congenital rubella. I have seen it in part of Turner syndrome. Routinely all Turner syndrome, we do one screening to see when we do echo We'll tell the cardiologist specifically, look, rule out coarctation of aorta. Next question. An unconscious child is brought to the casualty. What is the correct sequence of management? Assess breathing, pulse, response, start compression, bag and mask, ventilation. Yes, I think option is C here, that you will do assess response first, then assess breathing, assess pulse, start compression, then do bag and mask ventilation. One good thing that response here is, yes, I see the response here. C, correct. Only few have written C, right? Here, please remember, first you will do assess response breathing, then you will see pulse, start compression, and then do bag and mask ventilation. One good thing now, I'll go quickly through this because every one of you, by the time you become intern, you are getting trained to do CPR. So, and you know the algorithm to go forward. Please go through the books and be sure with this. Next question, which of the following statements are true regarding cytomegalovirus infection? Neonates are asymptomatic at birth, have lesser risk of later sequelae. 20 to 40% are symptomatic at birth. In developing countries, the rate of transmission of CMV infection to infant is more common from primary maternal infection than reactivation. Diagnosis by urine specimen at 4 weeks of age. Yes, correct. I think Dr. Jain has written the correct answer D. That is, D is neonates who are asymptomatic at birth are very unlikely to have risk at a later sequelae. And diagnosis and developing countries, rate of transmission of CMA infection to the infant is more common from primary metal infection than reactivation. These two are correct. So 1 and 3 response is D. So answer is D here. Yeah, I think few got it right, but Sakshi, I think for one Sakshi did A. No, it's not A. 20. The hormone that does not play a role in the growth of the fetus is insulin, growth hormone, thyroxine, glucocorticoids. This is the type of MCQ I like. Okay, right. A short question, short to the point answer, and very easily we can do. If this type of question is there, I don't mind answering 300 questions. Okay, yeah, growth hormone, correct. Growth hormone plays a role later in life, not in infancy. Okay, right. So fetus, no. So the fetus, the hormone that's important for us is thyroxine, insulin, and steroids. Okay, growth hormone role is later. Which of the following statement is true regarding tape shown in the image? Shelter's tape to assess severe malnutrition. Reading 13.5 to 14.5 is considered as undernourished, mainly useful for the frontline workers. So you'll opt for which options here? B, correct. B is correct. I think everybody found it easy. Very good. It's not Shelter's tape, so it's a Shakir tape. Okay. Severe malnutrition, right. Field front health workers, right. Okay. So reading 13.14.5 is wrong. So here when you say Shakir tape, more than 13.5 is normal. 12.5 to 13.5 centimeters is borderline. Less than 12.5 is wasted. Okay, so red, yellow, green, this is Shakir tape. Which of the following is true statement about congenital CMV infection? 20-30% of the infections are symptomatic. Triad of sensorineural hearing loss, periventricular calcification, enamel hypoplasia. Most children are asymptomatic at birth, can develop conducting hearing loss later life. If mother is IgG positive for CMV, child is unlikely to develop infection, which is correct. I think Dr. Jain got it right and Sahu Patil also got it right. D. Mother, if it's IgG, that means she's got it long back. Okay, so she's unlikely to transfer. She's IgM positive means recent infection. So the answer is D here, that is 22. Going to the next question. Which of the following is given as a part of therapy for a child with severe COVID? Corticosteroid, ivermectin, remdesivir, all of the above. Yeah, I see KK right. KK and Sahu Patil right. That's corticosteroids. Okay, this is the only drug that is proved. Okay, rest all are all. So I think many are writing A now. Tarun Rao, there is no 3A. What is 3A there? Okay, A is right. Okay. So it's corticosteroids that is used, proven beneficial. We started within 3 to 5 days, start tapering by 7th day and use it for nearly 2 weeks. So short course steroid, stiff course for 3 to 5 days and then taper over 1 week. Okay. No definitive role for remdesivir and ivermectin in children. A child presents with fever and vascular lesion of the upper limb and the lower limb. Neck stiffness is present. The similar lesion in the palm, sole and oral cavity. CSF analysis revealed normal glucose level and elevated lymphocyte protein. What's the most likely diagnosis? Is it bacterial meningitis? Is it Coxsackie? Is it herpes? Is it TBM? I think all those who have worked in the ward will answer very quickly. You won't waste time at all. It is hand, foot, mouth disease with CNS complication. And here, please remember, CSF sugar is normal. Okay, protein is increased, cells are there. So the typical hand, foot, mouth disease, CNS complication, it can come like meningitis. So LP here, remember the sugar was normal. Next question, match the following. Again, this question, again, this type of MCQ is not my choice. Fine, but fine, I'm going to answer it. Transfers objects, social smile, pincer grasp, walks 1 to 2 steps. And you will probably do this now. Normally, the baby transfers object by 6 to 7. Social smile by 1 to 2. Pincer grasp by 9 to 12. And walks 1 to 2 steps at 12 to 15 months. So the answer is here. Yeah, I think many got it right. Tarun, KK, Jane, Sophia, all have written B, which is correct. So it is B is 1B, 2A, 3D, and it's become like this only. So it's very easy. This I'll go quickly. I think it's there in the book. Everybody should know milestones till the age of 5. Which of the following congenital heart disease has equal saturation of in all 4 chambers of the heart? Tetralogyophalus, total enormous pulmonary venous drainage, tricuspid atresia, transposition of blood vessels. Yeah, I think I see answer B. Very good. D is not the correct answer, Tarun. It's B. Okay. Total anomalous pulmonary venous drainage. This is where the vein will drain into the right atrium and there is admixture. Usually there has to be some connection between left and right atrium, and then this one condition, all 4 chambers show the same saturation. So answer here is TAPVC. So TAPVC pulmonary, there is connection between right atrium and great veins, and instead of connecting to the left atrium, it drains into the right atrium. Usually there's something like atrial septal defect like will be there to maintain life. And in this condition, oxygenated, deoxygenated blood mix properly. So all 4 chambers have the same saturation. At what age does a child attain half height of the adult height? What is the age? 12 to 18 months, 20 to 24, 30 to 36, 40 to 48. Yes. Yes. It's B, which is right. You know, you become double your height at 2 to 2.5 years. Okay. So, you know, the second year height is very important. You know, 2 to 2.5 years, whatever height is there, you are likely to be double that in adulthood. The answer is B. Easy question. And this table is very important from pediatrics point of view. I always tell people to remember 50 at birth length, then becomes 25, 12.5, 6 to 7, 5 to 6, and prepubertal growth is 10 to 12 centimeters. Remember 50, you gain 25 centimeter in the first year. Then you became 12.5 in the second year. You gain per year. Okay. So normal growth velocity is this much. So it's good to remember this, and remember your height becomes double at 4 years, and second year height is like expecting double at adulthood. NADA's minor criteria includes systolic murmur, grade 3 major criteria, diastolic murmur major criteria, abnormal second sound minor criteria, abnormal BP minor criteria. These two are correct. Abnormal heart sound, abnormal BP is a minor criteria in NADAS, and this is good to remember. Here, you to have a congenital heart, you need two major or one major and two minor criteria. The next question: an 18-month-old child with 3 days history of watery diarrhea vomiting presented with altered sensorium. Which of the following is a differential diagnosis? Severe dehydration, HUS, then venous thrombosis, cerebral venous thrombosis, hyponatremia. 3 and 4. I see many questions are answered as C. Very good. I think you finished revising pediatrics today. Very good. Hemolytic uremic syndrome is not. It's not the option here. A child with diarrhea can have severe dehydration, can have thrombosis and hyponatremia, because of which the child will have altered sensorium. Whereas hemolytic uremia syndrome, there is a preceding history of diarrhea, not during the diarrhea period. Okay, so hemolytic uremia syndrome comes as a preceding history, and there is anemia, thrombocytopenia and AKI. So in diarrhea, if there is altered sensorium, think of hyponatremia, maybe think of thrombosis, or maybe think of severe dehydration. The causative agent of the condition shown in the following image is associated with which of the following disorder? Gingivostomatitis, Purette cell aplasia, molluscum contagiosum, Kaposi sarcoma. Only one. Sakshi has written B. Very good. Purette cell aplasia. Okay. Here, parvovirus is known to be associated with Purette cell aplasia. Please don't go for the other option. Molluscum won't come like this. Kaposi sarcoma doesn't look like this. Gingivostomatitis is typical of herpes. So parvovirus is known to be associated with Purette cell aplasia. So B is the right answer. Which of the following least risk of perinatal transmission? We're coming to the end of it already. You had 1 or 2 minutes more. Here, rubella. Rubella risk is maximum in the first trimester only. Towards the end, it becomes less and less. It will not be perinatally transmitted. So, KK, why did you write D? No. Yeah, D is the right answer, correct. It is rubella which is least risk of perinatal. Rubella damages the fetus in the first trimester, and that is known to produce PDA, sensorineural deafness, arthritis and congenital heart disease. Okay. So, and cataract also. 6-year-old boy is brought with history of chronic cough, false smelling sputum, false smelling stool, sorry. Sibling has similar complaint. Sweat chloride, CFTR gene is positive, and this gene encodes which of this? KK is right, chloride. Okay, typically here the chloride channel is blocked. So there is abnormality in chlor. Okay, so the answer is chloride. That's A, that's right. 4-year-old presented with fever, conjunctival congestion, erythematous disc formation. Video echo shows coronary aneurysm. Which is the first drug to give? Sakshi? No? IVIG. So it's Kawasaki disease. IVIG is the first. So quickly, in Kawasaki, IVIG, steroid and aspirin. Okay. So first to give is IVIG, and the IVIG should be given within 10 days. High fever, high platelet ESR, not responding to antibiotics. And then typical picture of bulbar conjunctival congestion and a very beefy tongue, And then you think of Kawasaki. In Kawasaki, IVIG, steroid and aspirin. Pompe disease. So I'm going to stop. Here the answer is alpha glucosidase. Answer is A. In Pompe disease, the deficiency is in these enzymes.